Now let us look at the pre-anesthetic medication that is given before any surgery. The body of the patient is prepared, so the surgery becomes smooth, safe, and predictable. This is the pre-medication phase, okay? Preparing the battlefield. Now the patient is very anxious, stomach may be full, secretions may be present, reflexes are active. But now, if we induce anesthesia directly, complications would occur. So we must prepare the physiology first. What is the goal that is to be achieved here? 5 targets: to reduce the anxiety of the patient, to prevent vomiting, reduce secretions, stabilize the reflexes, and reduce amnesia. What anxiety, vomiting, secretions, amnesia, and reflexes? ABSR. Anxiety, amnesia, vomiting, secretions, and reflexes. Anti-anxiety drugs are given, sedative hypnotics are given, opioids are given, anticholinergics, acid antiemetics are given, acid-reducing drugs are given, and one more thing is dexmedetomidine. Dexmedetomidine. So anti-anxiety drugs, they act where? Limbic system, the fear center, diazepam orally, lorazepam intramuscular, midazolam intravenous. What effect it produces is patient becomes calm, doesn't remember surgery, anterograd amnesia will be there. Patient will say, I remember going to OT, but then what happened? I don't remember. Sedative hypnotics, so like bromethazine are given. They're special because they're sedative, antiemetic, and they're anticholinergic effect. 3 in 1 drug. Bromethazine, it's a sedative hypnotic, and especially it is used in children. Opioids, they are the pain control before the pain starts. They control pain before pain really starts, and those are morphine, ethidine, okay? Ethidine, fentanyl. Fentanyl is preferred. Then it acts in the spinal cord and the brain pain pathways. Effects it produces are pre and post-operative analgesia, loss of pain sensation, and it reduces the anesthetic dose requirement. Now, important shift we must remember here is that the use of these opioids is limited due to their side effects, but fentanyl is preferred because it is short-acting and it is controllable. Anticholinergics to be seen, they dry the patient, like atropine, hyoscine, glycopyrrolate. They act at the muscarinic receptors. The effects they produce, they lower the salivary secretion, lower bronchial secretion, prevent the vagal bradycardia. Okay, it is an anticholinergic, it will prevent the vagal bradycardia. Without this, airways filled with secretions and there is risk during intubation without giving anticholinergic. Glycopyrrolate is advantageous over the atropine and hyoscine since it is a strong anti-secretory and it has less CNS effects. Antiemetics are given, they protect the airway from aspiration. During anesthesia, reflexes are lost, vomiting can occur, aspiration, whatever the food particles, they can be aspirated, then that can be fatal, aspiration into the lungs can occur. And the drugs, antiemetics, which are used are metoclopramide, it has antiemetic property, it is prokinetic, it empties the stomach. Then domperidone, it is similar to the metoclopramide, but it does not have any EPS, extrapyramidal side effects are not seen with domperidone, even though it is domperidone, haloperidol, properidol, these are also butyrophenones, the typical antipsychotic drugs. Ondansetron, it is a serotonin blocker, it is very effective post-op vomiting control, it blocks serotonin receptor in the C3Z. Chemoreceptor trigger zone. Acid reducing drugs make the stomach safe. Why? Because if aspiration happens, if there is less acid in the stomach, less lung damage will occur. How? I don't understand this, bro. What is this thing? Acid reducing drugs, they make the stomach safe, and inside the stomach, less acid. And if less acid, wala food particle is aspirated, then it will damage the lung relatively less. Okay, I got it now. And the drugs, acid reducing drugs are lamivudine, famotidine, omeprazole with domperidone. It's a preferred combo, domperidone with omeprazole. Domperidone has antiemetic, anticholinergic, antihistaminic property, and if it is used with acid reducing drugs, it is more preferable. It not just empties the stomach, but makes it less dangerous because it's reducing the acid concentration there. Next drug is dexmedetomidine. It's a modern star, if you imagine. Dexmedetomidine. So dexmed and tom. Dexmedetomidine. It acts at the alpha-2 receptors, central receptors. It will act as a presynaptic inhibitor. Alpha-2 receptors are present on the presynaptic receptors, so it will, whenever norepinephrine will be there in the synaptic cleft, it will get attached to the alpha-2 receptors and it will cause less release of norepinephrine from the presynaptic membrane, and hence it will cause sedation, decreased sympathetic response, decreased anesthetic requirement, and there is no respiratory depression. It is a very beautiful advantage of dexmedetomidine that it does not cause respiratory depression, and clinical use in the ICU for sedation and as a pre-anesthetic. Putting it all together, real OT flow, how a patient will get ready for actual general anesthesia will be before surgery, patient gets benzodiazepines to calm and for amnesia, for the loss of memory, anterograd amnesia. Then opioid is given for pain control, anticholinergic is given to dry the airway, antiemetics are given to prevent vomiting, acid blocker is given to protect the lungs if aspiration occurs. Now the body is optimized for anesthesia. Let us recall anti-anxiety drugs, diazepam, midazolam, lorazepam, for sedation and amnesia. Opioids are the painkillers, morphine, fentanyl, analgesia, anticholinergics are the reduced the secretions, atropine, glycopyrrolate. Glycopyrrolate has an advantage that we saw. The advantage was it is a strong anti-secretory and it has less CNS effects. Then antiemetics are the ondansetron, metoclopramide. Then it prevents vomiting. H2 blocker, ranitidine, and omeprazole with domperidone. It reduces the lactic acid. Alpha-2 agonist, dexmedetomidine. It causes sedation without respiratory depression. It reduces the anesthetic requirement also. Metoclopramide, ondansetron, and domperidone also is used. Then the questions: why is glycopyrrolate preferred over atropine? Because it's less CNS effect and it's a stronger anti-secretory. Why is ondansetron superior to metoclopramide? Ondansetron, it is a histamine blocker. Okay, wait. Metoclopramide and ondansetron. It's a histamine blocker and it is very effective. Whereas metoclopramide is a prokinetic. It empties the stomach. It's also an anti-emetic, but it's a stronger one. I'll have to point out to you. This thing. And why are H2 blockers given before surgery? H2 blockers will reduce the gastric acid secretion and they will reduce the risk of lung damage if aspiration occurs. Why is fentanyl preferred over morphine? Fentanyl is preferred over morphine because it's short-acting and it is controllable. Okay. And what is the advantage of dexmedetomidine over benzodiazepines? This will not depress the respiration and yeah, both will cause sedation, but without respiratory depression is the dexmedetomidine. I will find out the answer to this. So on and on over. Uh, it has superior safety profile with significantly low risk of serious neurological side effects.